afternoon, everyone, and welcome to the Vivian A. and James L. Curtis Center for Health Equity Research and Training. My name is Daphne Watkins, and I'm the director of the Curtis Center, professor of social work, and a university diversity and social transformation professor here at the University of Michigan. I am pleased to welcome you to the Curtis Center Health Equity Seminar. Today's speaker is Dr. Anao Zhang from the University of Michigan School of Social Work. And in just a few moments, Dr. Jacqueline Hawkins will announce our speaker. But before we do that, I want to begin by acknowledging the land that we're on. The University of Michigan was formed and has grown through connections with the land stewarded by the three Fires people who are the Ojibwe, the Odawa, and the Potawatomi, along with their neighbors, the Seneca, Delaware, Shawnee, and Wyandot nations. Now, I would like to share a few housekeeping items with you. First, we have activated the live transcription feature for this Zoom webinar, so please be sure to turn this feature on if you would like closed captioning. Second, should questions arise during the presentation, we ask that you place them in the Q&A box and we will address them at the end of the presentation. We are planning for about a 40-minute presentation by Dr. Zhang, followed by 10 minutes for Q&A. For those of you who are here for continuing education credits, I'd like to have Aaliyah come back and give you a little bit of information about how to complete those.
Thank you, Dr. Watkins. Hi, everyone. My name is Aaliyah Wessela. I'm the Director of CE here at the School of Social Work. If you would like CE for today's presentation, please be sure to stay the entire time. And we're going to have some live polling during today's session, which will be part of our attendance record. This is to demonstrate that you're engaged in paying attention during the session. And we also just like to see those audience responses come in. So please plan to participate with us via those polls. And if you have any issues in making that work with your setup, we also welcome your responses in the chat if you're not able to participate in the polls. I will talk you through that during our first poll, so you'll know what to do. If you have any other questions about continuing education, I'm also going to be here and available via the chat function. So please get in touch with me there if you would like to know more. Thank you.
Thank you, Aaliyah. And now I'd like to introduce Dr. Jacqueline Hawkins, who is an assistant professor of social work and associate director for the Curtis Center for Health Equity Research and Training here at the University of Michigan. Dr. Hawkins is going to introduce our speaker for the day.
Thank you, Dr. Watkins. My name is Jacqueline Hawkins, and I just want to take a moment to introduce our speaker. Dr. Anao Zhang is an assistant professor of social work at the University of Michigan and the clinical research director of the Adolescents and Young Adults Oncology program at Michigan Medicine. Zhang is a health and mental health intervention researcher with a primary research interest in psycho-oncology and adolescent and young adult cancer survivorship. An intervention researcher by training, Zhang contextualizes his work using the social determinants of youth health framework and aims to develop and deliver integrated and empirically supported mental health treatment to individuals with comorbid physical and mental health conditions. Zhang is also an applied quantitative methodologist who uses advanced statistical methods to support his research, including meta-analysis, structural equation modeling, analyzing experimental data, causal inferences, and machine learning. Zhang serves as an associate editor for the Journal of Psychosocial Oncology and the deputy chair of Survivorship Special Interest Group at the International Psycho-Oncology Society. Clinically, Zhang is a licensed clinical social worker, a member of the Academy of Certified Social Workers, and a diplomat of the Academy of Cognitive Therapy. Zhang has over 5 years of clinical experience in various hospital settings and specializes in solution-focused brief therapy and cognitive behavioral therapy. And with that, I'll hand the floor over to our speaker.
Thanks, Dr. Hawkins, for that introduction. I hope everyone can hear me okay and see the slides okay. All right. Good afternoon, everyone. My name is Anao Zhang, and I appreciate the opportunity to share with you on the topic of health equity among adolescents and young adult cancer survivors, and to talk a bit on this population's unique challenges related to health and mental health disparities, and how our team at the University of Michigan, both the academic and the medical campuses, are working together to overcome these challenges to create a more equitable system for AYAs living with cancer. Before we start, I always want to remind my audience that to be mindful that we're going to have a conversation related to cancer. In one way or another, it is most likely that our lives are all impacted by cancer, and sometimes discussions and conversations on cancer can potentially be triggering. So please just be mindful of this and remember to take care of yourself if you need to throughout the presentation. And for today's presentation, I would like to start by covering the broader context of cancer incidence and mortality rates in the United States over the years, then dive further into the unique biopsychosocial, spiritual, and clinical challenges and needs confronting the AYA cancer population. In the later half of the presentation, I want to highlight some of the works that are happening at the University of Michigan to directly confront these challenges, and finally to conclude the presentation by sharing our future goals in the next 3 to 5 years. And before we start, we have our first polled question. The question asks you to think about, at the US population level in general, how are we doing in preventing cancer incidence and in treating cancer death rate over the past decade? Are we improving in both areas, only in cancer incidence, only in cancer death rate, or in neither of the area?
All right, everyone, this is our first poll. It looks like folks are finding out what they need to do here. You just click a response if the poll has popped up on your screen. If you are not seeing the poll pop up, which sometimes happens on tablets and other devices, please feel free to provide your response in the chat. Thank you. We'll leave this open a little while longer for folks to respond. All right, I'm going to go ahead and share the results.
All right, so it seems like we have somewhat of a mixed divide between we improved in both cancer incidence and death rate versus there's another big group of folks responded that we improved only in cancer death rate, but not in the incidence rate. So the correct answer is C, we improved only in cancer death rate, but not in the incidence rate. And let's just take a closer look of the annual rates of new cancers and cancer deaths throughout the years between 1999 to 2018. So overall, how we're doing. The latest data that we have from the Centers for Disease and Controls and the National Cancer Institute reported that in terms of the annual rates of new cancer cases, which is the graph on the left side of the slide, the United States reported an age-adjusted rate of new cancer cases of 481.7 per 100,000 people in 1999, whereas in 2018, where we have the latest data for, the age-adjusted rate of new cancer cases per 100,000 people was down to 435.8. It is important to note that there was a noticeable falling trend between the years of 2008 and 2013, with a statistically significant annual percentage change during that time period. Otherwise, the annual rates of new cancer incidents remained relatively stable, meaning we're not necessarily making meaningful progress in preventing cancer incidents over the past decades. That's including between 2013 and 2018. On the other hand, however, we are making relatively good progress in treating cancer. As you can see in the graph on the right side of the slide, the age-adjusted cancer death rate in the United States reduced from 200.7 per 100,000 people in 1999 to 149.2 per 100,000 in 2018. And this represented a 32% decrease from its peak back in 1991, which translates to almost 3.5 million fewer cancer deaths during these years than what would have been expected if the death rate had not been falling. According to the American Cancer Society, the continued dropping rate of cancer death is largely because of fewer people smoking, which resulted in declines in lung and other smoke-related cancer, and in conjunction with other factors, especially the advances in cancer treatment and the much improved prevention and or early detection of cancer at the population level. Another important indicator when we think about advances in cancer treatment and in cancer care in general is the patient's 5-year survival rates. As you can see in the latest data from the Journal of National Cancer Institute SEER program, each pink dot in the graph represents the site-specific 5-year survival rate between 1970 and 1977, and each blue dot represents the site-specific 5-year survival rate between 2007 and 2013. And if you see an arrow pointing towards the right direction, it indicates an increase in the 5-year survival rate of a specific cancer site. Whereas if an arrow points towards the left direction, it indicates a decrease in the 5-year survival rate of a specific cancer site. So by and large, we see a significant improvement in the 5-year survival rate across all types of cancer, which is highlighted in the green rectangle, though the improvement differs a lot by specific cancer sites. For example, as highlighted in those blue rectangles, that we can see significant improvement in the 5-year survival rates for prostate cancer, leukemia, and myeloma. But we also see reduced 5-year survival rates for uterus and cervical cancer. It is also noticeable that the 5-year survival rate of cancer also vary a lot by different populations, which is not shown in this figure. And here's our second question, which asks your opinion on, or your thoughts on, which racial ethnic group has the highest cancer death rate across all cancer diagnoses. Non-Hispanic white, non-Hispanic Black Americans, non-Hispanic API Americans, or Hispanic Americans.
All right, our responses are coming in. We'll give it a moment longer. I just want to note, in case everyone's like really hesitant to respond, you do not need to get the poll questions right in order to have your attendance count for CE today. All right, I'm going to end the poll.
All right, it seems our audience by and large did a good job of identifying probably one of the most salient disparity gap in cancer death rate, that is non-Hispanic Black Americans has the highest rate of cancer death in the United States across all races and ethnic groups. So despite the overall significant improvement in cancer death rate and a patient's 5-year survival rate, as I showed you a couple of slides ago, cancer health disparity in certain populations is an area in which progress has not kept pace. For example, data from the 2015 to 19 documented Black Americans have the second highest rate of cancer incidence and the highest rate of cancer death when compared with other racial and ethnic groups. And certain observed health disparities are even more pronounced within specific cancer sites. For example, Black men have the highest rates of prostate cancer incidence, and other than their non-Hispanic white counterparts, the rate of prostate cancer incidence among Black men are 2 times or greater than most of the other racial and ethnic groups. And if we look at the prostate cancer death rate, Black men have higher rates of prostate cancer death rate, with more than double the death rate than other race and ethnicities. Disparities in cancer incidence and/or death rates are also seen in people in low socioeconomic groups and those living in geographically isolated areas. Lack of medical coverage, barriers to early detection and screening, and an unequal access to improvements in cancer treatment may contribute to these observed differences. Previous and ongoing research have also found some underlying biological differences that intersect with other psychosocial factors that contribute to health disparities. For example, a particular aggressive form of breast cancer, the triple-negative subtype, is more common among Black women than women of other racial and ethnic groups. Most strikingly, studies have found that Black women had nearly a 3-fold increased risk of triple-negative breast cancers, which have poor prognosis. It is still contentious whether the significantly increased risk of triple-negative breast cancer among Black women is primarily driven by psychosocial related health disparities, or it is indeed a molecularly distinct disease. Latest discussions on this, one of the most significant examples of racial disparity in oncology, considered both the genetic predisposition of triple-negative breast cancer among Black women, which is further exacerbated by various socioeconomic related disparity, such as obesity and poor access to screening and cancer care. And here enters our third poll, which asked your thoughts on what do you think is the single most important risk factor or significant risk factors for cancer overall, that is across all cancer types? Is it alcohol, age, diet, using cancer-causing substances? All right, seems like over half of the majority did get the right one. That is, age is the single most important risk factor for cancer overall. So among the many risk factors impacting individuals' cancer risk, age is the most significant risk factor for cancer overall and for many individual cancer types. In today's presentation, though, I would like to draw your attention to a unique age cohort that is between 15 to 39 years old, often referred to as the adolescent and young adult cancer population. And before we move forward, I just want to quickly define 2 terms to be used for the remainder of this presentation. In cancer, a person is considered to be a survivor from the time of diagnosis until the end of life. So that is inclusive of newly diagnosed cancer patients, patients receiving active cancer care with curative intent, patients receiving palliative care and/or end-of-life care, as well as those individuals who have completed their curative cancer treatment and are now in the post-treatment survivorship phase. And second, in this presentation, I align my definition of AYA with the National Cancer Institute, which refers to those individuals with a cancer diagnosis between the age of 15 to 39 years old. In the United States, overall, there were close to 90,000 new cancer cases and over 9,000 cancer deaths in the AYA age cohort into 2020. And latest data from the American Cancer Society reported close to 650,000 survivors of AYA cancer living in the United States in 2021. Despite rapid progress in the scientific understanding of cancer in AYAs, important research gaps in etiology, basic biology, treatment, and survivorship persist, partly because this age group continues to be grouped with children and or older adult in many clinical care programs and epidemiologic studies. And even for studies that focus on the AYA population, data are often presented in aggregate, masking important differences across the AYA age group, which includes several developmental stages. And then I think it's worth just to talk a little bit about how the AYA cancer population, not constituting a large proportion of the general cancer population, how it received the national attention in the first place. So about 2 decades ago, the AYA age demarcation was established as a high-risk population after data from NCI showed a lack in improvement in survival for patients with many forms of cancer that falls within this age range. This means that with the same cancer diagnosis and disease progression, AYAs benefit the least from advances in cancer treatment when compared with their peers who are in the pediatric age cohort and or in the older adult age cohort. Some noted factors contributing to this historical gap include age-dependent differences in disease biology of certain cancer diagnoses that are specific to the AYA population, reduced rate of clinical trial enrollment, and the lack of treatment standardization for AYAs diagnosed with cancer, delays in diagnosis and receiving cancer treatment among the AYA population, and limited access to healthcare due to higher chance of being uninsured given the nature of AYA's developmental stages. With the nation's attention to AYA cancer since the early 2000s, we have come a long way in terms of our understanding of the values, the care, and the outcomes for AYAs with cancer. But there's still a lot that we don't know and need to learn, especially when it comes to fulfill the unique biopsychosocial spiritual challenges confronting this age population. As I will make a case soon in this presentation, in addition to the common health and mental health disparity related factors that pertains to individuals with cancer across all ages, AYAs are additionally confronted with biopsychosocial, spiritual, and clinical challenges that are unique and specific to this age cohort. And most importantly, within the AYA age cohort, we observe striking and persistent disparities found in the 5-year relative survival rates of common cancers diagnosed in AYAs based on race and ethnicity, socioeconomic status, and sex and gender identification, and geographical location of a patient's residence. Great progress have been made in identifying and studying psychosocial and biogenetic factors' role on key outcomes related to cancer, such as access to care, health behaviors, and increased cancer risk, which in turn impacts the cancer health outcome among individuals diagnosed with cancer. To my knowledge, however, there has been few studies that focused on evaluating the relationship between psychosocial factors and the biogenetic factors in relation to cancer occurrence, recovery, and survivorship outcomes among AYAs. For example, one may be curious if certain gene behaviors at the biogenetic level are subject to the influence of social and environmental risk factors and are being the precursor to bad cancer health outcomes. And an exciting study that I will share towards the end of today's presentation, happening right here at the University of Michigan, addresses exactly that. And before we move forward, we have our fourth polled question. We talked about the AYA age range between 15 to 39 years old, and how many developmental stages do you think are included in this age range?
All right, gonna give it another moment. So we get a few more responses in. All right, thanks everyone for your participation.
Great. Okay. So we have the majority of you who said 3 stages. That is correct. So as we start to consider the unique biopsychosocial, spiritual, and clinical challenges, let's start with the biodevelopmental challenges facing AYAs with cancer. It is important to recognize that the 15 to 39 age spectrum contains 3 distinct developmental stages. That is the mid to late adolescence, the emergent adulthood between 18 to 25, 26 years old, and the young adulthood, which is 26, 27 to 39 years old. As you probably already can tell, there are numerous developmental milestones across the 3 developmental stages that are significant to the development and the lifelong wellness of an individual. And overall, during this stage of our life, individuals, that's AYAs, would anticipate good health during this period of time. However, being diagnosed with cancer significantly disrupts AYA's expectation of optimal physical health and then exposes them to the premature confrontation of a potentially terminal diagnosis. That's including death anxiety and other factors. And then additionally, AYAs with cancer often experience body and appearance changes due to certain types of cancer treatment, all of which have both immediate and lifelong implications to the healthy development as well as the wellness of this age population. And in addition to the major disruption to AYA's developmental trajectories, common side and late effects of cancer treatment often causes difficult to manage symptoms such as chronic fatigue, nausea and vomiting, bleeding and bruising, among other common problems that may potentially stay with the patients for the remainder of their lives. And one key area that is representative of the biodevelopmental challenges specific to AYA cancer survivors is the field of oncofertility. Oncofertility is a subfield that bridges oncology and reproductive research to explore and expand options for reproductive future of cancer survivors. It involves the discussion of risk to fertility and fertility preservation options, as well as the management of related complications such as pubertal delay, menstrual irregularities and bleeding, hormonal deficiency, and sexual dysfunction, just to name a few. And many of these issues are uniquely experienced by AYAs given their developmental characteristics. Provision of information to and psychological support for the patients, their partners, and parents is integral to oncofertility care. While it is almost a no-brainer that we need to provide high-quality oncofertility care to AYAs diagnosed with cancer, there's simply too much that we don't know to guide the best clinical practices. For example, when is a good time to raise and discuss the issue of oncofertility? It is, of course, ideal to have a conversation about oncofertility with AYA cancer patients before the start of any cancer treatment to avoid potential permanent damage to the patient's future reproductive capabilities. However, as many patients are still processing the initial shock in reaction to their new cancer diagnosis, studies have reported that many AYA cancer patients either retain oncofertility-related information very ineffectively or felt pressured to make fertility decisions when they are not prepared to do so. It becomes an even more complex clinical issue when oncofertility intersects with the patient's sex and gender identity and/or their current relationship status with intimate partners. For example, how can we make sure that AYA cancer patients make autonomous oncofertility decisions while incorporating input from their intimate partners that are also essential to their disease experience and their quality of life? Before we move forward, we have our last poll for today's presentation, which is ask your thoughts on the prevalence of clinically significant psychological distress among AYA cancer survivors and how that compares to the general population.
All right, we'll wait for a few more responses. All right.
Great. Okay. So most of you said it's 2 to 3 times greater than, and I think maybe 1/3 of you were more pessimistic about 3 to 4 times greater than. So clinical studies actually reported up to 45% of the AYA cancer survivors with major depression or anxiety, which is 3 to 4 times greater than the rate in the general population. And the general population rate was estimated to be between 10.4 to 15% for major depression and anxiety in the United States in 2018. So not surprisingly, AYA cancer survivors also face a multitude of psychosocial challenges, both during and after the completion of their cancer care, that often leads to high levels of psychological distress. Commonly known factors contributing to distress among AYA cancer survivors include disconnection from peers and the increased sense of self-isolation, fear of cancer reoccurrence and death, major and chronic depression, which often are associated with treatment-related side or late effects, emotional distress associated with disease progression, the transition from dependent to independent healthcare as AYAs get older, and there are many other related factors. A salient disparity-related factors among AYAs is the access barrier to evidence-based mental health interventions. Studies have reported over 40% of AYAs with cancer in need of mental health counseling do not receive the care, and factors contributing to this major disparity include a significant mental health workforce shortage, especially for those with specialized training in mental health and psycho-oncology. Another factor are time barriers to receiving mental health due to an already hectic cancer treatment, and then also because many AYA cancer patients receive cancer care from comprehensive cancer centers that are often far away from their home of residence. So they may not have the necessary time and resources to receive in-person psychological therapies. And this has highlighted the urgent needs to create brief AYA and cancer-specific and technology-assisted mental health interventions for AYAs diagnosed with cancer. Another significant disparity for AYA cancer survivor is the lack of inclusive and evidence-based care for minority AYAs. A recently completed meta-analysis by our team evaluated the psychosocial interventions among AYA cancer survivors, found fewer than 20% of racial and ethnic minorities are included in psycho-oncology behavioral clinical trials, reflecting a significant racial disparity gap in this area of research. And similarly, studies have found that sex and gender minority, the SGM-AYA populations, are often left out in psycho-oncology research, resulting in no or poor practice guidelines supporting SGM-AYAs with a cancer diagnosis. For example, clinical providers are in strong needs to identify practice guidelines when delivering oncofertility and oncological care to SGM-AYAs concurrently undergoing or who have recently completed gender-affirming therapy. All that is to say that there's just so much more that we don't know and we need to learn with regard to the inclusive and equitable practice in the AYA oncology care. Another key area to consider as we engage in the AYA cancer population is the consideration of spiritual needs among this population. Given the unique emotional and social life changes that takes place during this life stage, spirituality may play an important role in AYA's subsequent adjustment following cancer, serving as an important coping resource. We know already that adults' lifelong spirituality is formed during adolescence and young adulthood, and having cancer during this time may have lifelong influence on survivors' spirituality. Further, for AYAs facing the possibility of death may evoke more existential questions regarding the nature of suffering and mortality, which would in turn influence their subsequent spiritual lives. And all these factors are in a way unique to the AYA cancer population. A notable system-level disparity related to the clinical care for AYA cancer survivor is the transition in cancer care. Currently, most cancer treatment facilities adopt the model of pediatric versus medical oncology care. That is, there's an institutional boundary between pediatric oncology treatment facilities and medical oncology. The AYA cancer population, however, can receive care either at pediatric or medical oncology centers, and often each patient's treatment facility assignment is dependent on the ER that they're being admitted into. And this has resulted in seeing 22 to 25 years old AYAs being treated in a pediatric cancer hospital, and vice versa, a 15 or 17-year-old being treated in a medical oncology adult cancer center. In addition, as AYAs continue to age, most of them receiving cancer care in pediatric facilities will need to leave their oncologic team and seek service from a different team in medical oncology. In many healthcare systems, pediatric and medical oncology programs are often siloed, and the transition can be difficult to manage for many AYAs during transitions of care. It has been widely advocated across the country to institutionalize a new model of care for AYAs with cancer that connects both pediatric and medical oncology to facilitate a smooth care transition for this population. In addition, AYAs also face unique challenges as they transition from active curative cancer treatment to the post-treatment survivorship phase. Specifically, after a physically and emotionally exhausting battle with cancer, AYAs need to redefine the idea of normalcy, life priorities, reconnecting with family and peers, managing fear and uncertainty associated with follow-up procedures and risks of cancer reoccurrence. And yet they often felt alone and helpless during this period of transition, as they no longer have the well-layered support from their oncologic team during the course of active treatment. It is important to know that all the biodevelopmental, psychosocial, spiritual, and clinical challenges faced by AYA cancer survivors often co-occur and are intertwined. And I hope so far into the presentation, I've made a strong argument that challenges facing AYA cancer survivors are complex, dynamic, and intertwined, and should be addressed in a multi-level, it should be addressed at multiple levels simultaneously. I want to argue that to alleviate the complex challenges faced by AYA cancer survivors, it needs an interdisciplinary team of clinicians and researchers that integrates clinical care and research efforts that centers its attention to promote health equity. And I'm pleased to share some exciting efforts that are happening here at the University of Michigan that are aimed to confront these challenges, which is through the establishment and continued growth of the adolescent and young adult oncology program at University of Michigan Health. The AYA Onc program is funded by Teen Cancer America, and we officially kicked off our program in mid-2020 during the COVID-19 pandemic. The program is designed to be an umbrella program that covers various cancer clinics at the Rogel Cancer Center on the medical oncology side and the CS Mott Children's Hospital on the pediatric oncology side. This program does not provide clinical care to patients directly, meaning all patients would stay within their with their primary oncologists. And the program is designed to be an additional layer of support by providing clinical referrals and psychoeducational support, as well as resources for patients to bridge the institutional boundary between pediatric and medical oncology here at the University of Michigan Health. And I want to highlight 3 distinct features of the programs that would allow us to explore and implement multi-level solutions to the complex challenges and needs that are facing AYAs with cancer. First, the program is led and driven by a patient advisory council composed of AYA cancer survivors to guide all aspects of our programs. That is ranging from creating new program initiatives to the strategic use of program funding to improve our clinical care. Having a patient advisory council embedded at the center of our program, it allowed us to engage in true patient-centered care during the program's day-to-day operation. A second unique feature of our program is that it has integrative clinical and research arms that includes both clinicians and psycho-oncology researchers from an interdisciplinary backgrounds, including but are not limited to pediatric and medical oncology, endocrinology, epidemiology, social work, nursing, psychology, and communication science, just to name a few. With less than 1.5 years, we have attracted several outside collaborators across the nation, such as those from MD Anderson Cancer Center and U Chicago Medicine, joining our effort to apply for and implement multi-center studies that would allow us to include racial and ethnic minority participants, as well as sexual and gender minority AYA cancer patients in our clinically informed research effort. Having the integrative clinical and research arm of the program, we are able to engage in what we would refer to as bench to bedside psycho-oncology research, that is to conduct practice-informed research and to promote research-supported clinical practice. This structure allows us to translate clinically urgent and meaningful needs into research questions in a timely manner. One of our ongoing study that is representative of the type of work that we're very excited and it evolved out of our integrative clinical and research arms is the study entitled Evaluating the Clinical Utility of an Artificial Intelligence AI Enabled Voice Detection mobile app for distress monitoring among AYA cancer patients. Our study PI, Dr. Arthi Kamat, a pediatric oncology fellow, first from the left, is interested in exploring effective methods to monitor the trajectory of psychological distress of AYA cancer patients throughout their disease journey. Currently, the distress screening protocols are often poorly implemented in comprehensive cancer centers, and the longitudinal monitoring of AYA cancer survivors' distress is almost not existing. This has led to delayed detection of acute psychological distress among AYA cancer, resulting in major mental health disparities in this population. After a collaborative effort with the research team, we've selected a state-of-the-art mobile app that utilizes an AI algorithm to detect patients' psychological distress via a 90-second collection of the patient's speech data. That is, the patient talked to their cell phone for 90 seconds with prompt questions. The familiarity with mobile app among AYAs and the brevity of the 90-second interaction have clear advantages in reducing the stress screening burden for both clinicians and patients. And we have received funding from the Rogel Cancer Center aimed to evaluate and establish the clinical utility of the tool and plan for future evaluation of its efficacy in a multi-center trial. A final unique feature of our program I would like to share with you today is the centered focus on our committed effort to health equity. We are pleased to receive funding from the Curtis Center for Health Equity Research and Training to create a psycho-oncology fellowship to support predoctoral health disparity research on AYA sex and gender needs during cancer. Our predoctoral fellow Nina Jackson-Levin, who's a joint PhD candidate in social work and anthropology, is an integral member of the program and has led our program's explicit focus on engaging SGM-AYA cancer survivors. Currently, our co-medical director, Dr. Emily Wallin and Ms. Levin, are leading a study entitled Queering Oncofertility, Exploring Fertility and Preservation in the Sexual Health Counseling for Queer AYAs with Cancer. This project, funded by the Institute for Research on Women and Gender, allows us to highlight the involvement of SGM-AYA cancer survivors in oncofertility research. In another study led by Ms. Levin, we conducted a system-wide survey to evaluate the needs of all AYAs who have received or are receiving care in Michigan Medicine, with a particular focus to reach out to racial and ethnic and sex and gender minority AYAs. And I'm very pleased to report that we have received very promising returns from minority AYAs who are otherwise often left out in psycho-oncology research. During the past year, our program have produced, under the leadership of Ms. Levin's work, have produced 5 peer-reviewed journal articles, including 2 specifically that focus on health disparity. And just to give you an example of some of the work that we're doing, so one published article first authored by Nina was titled Queer Insights, Consideration for Assessing Sex and Gender in Oncofertility Research in the Annals of LGBTQ Public and Population Health. As indicated earlier in the presentation, a thorough understanding of cancer health disparity requires considering the complex interaction between psychosocial level factors and biomolecular level factors. Our program's research director, Dr. Bradley Zebrak, recently received a 5-year R01 from the National Cancer Institute to study the social genomic mechanism of health disparities among AYA cancer survivors. The grant will allow the study of molecular pathways that represent potential targets for interventions to protect AYA survivors against the adverse biological effects of social isolation, socioeconomic disadvantage, and other psychological and social determinants of health in the highly stressful context of cancer. The study's intent is to identify functional genomic pathways through which social and psychological factors influence gene regulation and alter health outcomes in AYAs, and to define the role of such effects in structuring health disparity in post-treatment survivorship. Innovatively, the study also plans to identify the genome-wide molecular correlates of vulnerable populations as structured by race and ethnicity, sex and gender identity, and geography, and define the relationship of those genomic profiles to AYA lymphoma survivors' healthcare outcomes. Just due to the constraint of time, for those of you who are interested in other work that we are doing here at the AYA Onc program, please just visit ayacancerresearch.com to explore more on some of the technology-assisted mental health intervention work that we're doing. And I have 2 more slides and I will conclude. And I would also want to just highlight one of the many exciting clinical activities that are happening here at the AYA Onc program. Our program is among the first oncology care programs in the country being considered for certification as an adolescent champion program by the Adolescent Health Initiative. The goal is to create friendly physical environment that effectively meets the various needs unique to AYAs with cancer, to build an inclusive culture of practices, and allow safe, private, and a clinically meaningful conversation between AYAs and providers, and to stimulate various initiatives and projects that support some top needs expressed by AYAs diagnosed with cancer. So very quickly, where we're heading to in the next 3 to 5 years. And I just wanted to disclose that these are not all the goals that we have, but some of the goals that I am very excited about. So we'll definitely to explore and evaluate strategies that allow the improvement in the AYA cancer population's clinical trial participation rate at the University of Michigan Health, which has been identified as a salient disparity gap in this population. We also hope to become a translational lab that introduces advanced technologies into the clinical care for AYA cancer survivors, either through the technology-assisted mental health interventions or by exploring the role of artificial intelligence and other advanced technologies in improving clinical care. And finally, we aim to continue to collaborate and to grow towards a national infrastructure of AYA cancer research, which would allow us to have this national platform to facilitate AYA-focused cancer research that is inclusive of racial and ethnic and sex and gender minority participants. And with that, I want to thank you all for your time, and I'm happy to answer any questions.
Thank you so much for that presentation, Dr. Zhang. Inspiring presentation too. So we do have a few questions that have come in, and so I'm going to keep my eye on the clock and see which one is going to make it to prime time. So let's see. Well, why don't I ask the first one that's here that came up as you were wrapping up the presentation, and it was speaking to this idea of team-based research, because I think one of the things that we were all able to see in your talk today is that you're collaborating with so many different scholars across different spaces, research and clinical. Can you say a little bit more about the value of team-based research when we're doing both research and clinical work with the AYA cancer community?
Absolutely. So the first word that pops into my mind is the word transdisciplinarity. So I differentiate that with interdisciplinarity and multidisciplinarity, and transdisciplinarity. And I think Dr. Watkins, you know, and I think many of the audience understand, is that so for us as researchers or providers or clinicians, we step out of our comfort zone, out of our professional boundary, but to start to think wearing the hat of other researchers or clinicians with different backgrounds of training. And I think that to me is the single most valuable component to team-based care. That is, it allowed us to even come up with those groundbreaking ideas, because we don't know what we don't know. And if we don't know how to ask the research question, there's no way for us to pursue that question. And I think the value with team-based care really comes in, and it exposes each individual member on the team with the different ways or even a shifting paradigm of thinking to a research topic that they've been trained or they've been oriented to think about. And I think that to me is the most valuable thing that I would want to highlight.
Okay, thank you for that.
Yeah.
Now, another question that came through was a question that came earlier in your talk, and it really spoke to, and I think I'm going to interpret this question correctly. I think what the person is asking is about the stigma associated with cancer for AYA communities, because I think there is this idea of cancer being something that happens to people who are not young, right? Something that happens possibly for folks who are older. And so the question asks, you know, how is this then managed? Because you spoke a little bit to some of the developmental factors that affect AYA communities, but can you say a little bit more about the stigma associated when that diagnosis is made? And
Sure.
how people who are suffering begin to sort of navigate that space.
Totally.
Within the stigma.
It's such a great question, but I would also say it's such a big question, right? Because the manifestation of cancer stigma it's almost at all the levels that we can even imagine. So for example, the stigma would manifest in both the younger and older AYAs interaction with their peers. So the stigma would manifest as if, you know, your friend would no longer start to call you or would behave differently as they, you know, learned that you have a cancer diagnosis. So that is also one way that stigma is managed. And so that's just an example to show that it's actually highly complex and almost all-encompassing when it's impacting an individual. One way, and I don't know if it's a good answer to that. And I think one way what we are doing here is, at least with our clinical arm, what we hope to do is to create a physical and psychologically safe environment that even acknowledges and understands, in a sense, accepts that stigma. That is, yes, it sucks to have cancer. yes, you've been treated very differently. Yes, people are walking on their toes around you and you feel so awkward and weird, and it's okay to feel like that. So and again, I don't think it's the answer to it, but I definitely think it's one of the good ways to respond to manage the stigma that's associated with the cancer diagnosis in this population.
Sure, sure. Thank you for that.
Sure.
And then let's see. Okay, I'm going to slide one last question in,
Sure.
and we're gonna wrap up. But it's a question that came through that I think caught a lot of people's eyes. It's this term that you use, this biopsychosocial, spiritual, and clinical challenges term, and I think it really speaks to the complexity and how so many things I think are intertwined, as you mentioned during your talk. So can you unpack that in 3 minutes that we have left, right? Can you unpack
Sure.
that a little bit more for us? Because I think it does elevate for us that this is not a very linear problem, and so there's not a linear solution to it. But talk to us about how you're weaving each of these pieces together to really address the needs for this community.
Totally. So I would definitely see it would require a big team, a team that, myself and my colleagues here are working on trying to build that. And I think different researchers and providers would approach that big framework slightly differently based on what they're most comfortable with, what their training backgrounds are in, right? So for example, with my background with training in social work, in mental health, in behavior intervention, so I'm mainly anchoring my perspective from the psychosocial perspective, but be very mindful of the biological implications, its impact on the psychosocial, as well as how to also be mindful or complementary to the spiritual challenges that may manifest or intersect with the psychosocial component. So I think by acknowledging the complexity of the intersectionality that are at play here, but also approach it from the perspective or maybe angle that each individual of us feel comfortable and most confident in handling that. And I definitely also throw in clinical, really to the credit of my team at University of Michigan Health, that just brings a lot of eye-opening kind of ideas when it comes to research about the clinical challenges that doesn't fit nicely into any of the biopsychosocial spiritual challenges, but it's all over the place. So that's another reason that I'm kind of adding that clinical challenge into that.
Sure.
Yeah.
Sure. Well, Dr. Zhang, thank you so much for your presentation today. I think we've all learned so much. And when it comes to advancing health equity, I mean, hands down, it sounds like you and your team are definitely doing just that. And so with that, we will go ahead and begin to wrap up today's webinar and thank Dr. Anao Zhang again for his presentation today. Everyone, please give us a round of Zoom applause for this presentation, and take care and enjoy the rest of your day.